Hello, everyone. Welcome to Navigating Schizophrenia, Part 1, which is a program of a 4-piece series where we are looking at the role of long-acting injectable antipsychotics. Today, it's about treatment options. My name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, Hempstead, New York, and I'm also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany. And I'm joined by very esteemed colleagues. First, maybe you want to introduce yourself, Les?
So happy to be here. I'm Dr. Leslie Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York.
And Rebecca?
I am Dr. Rebecca Roma. I'm a psychiatrist in Pittsburgh, Pennsylvania. I primarily work in clinical practice, and I also teach medical students and residents at the University of Pittsburgh School of Medicine.
Wonderful. So we are grateful that you're here, and we will discuss today long-acting injectable antipsychotics. This will be 4 different sections. What are long-acting injectable antipsychotics, or LAIs, and also which ones are currently available. Second, we will talk about where do they fit within the treatment plan, and you will hear some opinions from us about this, because I think we're here because we're strong believers that LAIs should be considered early and thoroughly, and can only be considered when you know about them. That's what we'll be talking about today, but also when they are offered in a certain way and when we know about the risks and the benefits and the alternatives. But when you think about an LAI, we also need to think about how to get there. And that's what we'll be talking about today, how to switch from an oral to an LAI formulation. And then once someone is on this medication, in this formulation, how do we actually monitor it? Because obviously we can't just give a so-called shot and then let the person go. It's part of a treatment algorithm. It should be a basket. So let's first talk about what are long-acting injectables and where do they fit? So long-acting injectable antipsychotics utilize different designs to achieve drug depot and extended release from the injection site. That's basically desired because, as you know, when you take a medication 365 times a day, or actually twice a day would be over 700 times, then things can get lost along the shuffle. And also, we have a lot of peak and trough variation. You basically put the medication into this mouth, and then the GI tract, it goes through the liver into the bloodstream, and then it sinks again until you give another medication dose again. Wouldn't it be wonderful to have the medication sitting and waiting there for it to slowly be released with relatively little peak trough variations to have a steady delivery of the medication? Obviously, this is not an idea that's new. We have that in many pieces and parts of medicine, but somehow we're doing a little harder and have a greater difficulty thinking about this in psychiatry. So LAI antipsychotics have higher bioavailability because they bypass the first pass effect, and thereby they can also somehow reduce the variability within and across patients, because you don't have the variability about absorption through the gastrointestinal tract. After an IM or sub-Q injection, the LAI drugs form a depot at the site of injection and then slowly release the active drug into the system circulation over either weeks or months or many months. And the rate of drug absorption depends on the drug properties, the particle size, how quickly they are broken down, water solubility, delivery vehicle, injection volume, as well as patient factors, body weight, fat, and injection site. The drug absorption rate is much slower than the elimination rate. Therefore, the time to achieve steady state is determined not by the half-life or breakdown, like in oral treatments, but by the absorption rate. That's called flip-flop kinetics. Compared with oral antipsychotics, the slow absorption leads to a more predictable and stable plasma drug concentration, which we believe is desirable. Now we have first-generation LAIs that are formulated on an oil-based vehicle. They slowly release the decanoate or ester into the systemic circulation, but oil gets into water of the cell, and that can be more painful. Second generation antipsychotics are all water-based, and that makes sense because the solubility makes it less painful for them, but they basically are low soluble and are form esters or salt forms, and also can have prodrug forms, and we'll hear from Professor Citrome about that. And there can be also polymers or microsphere depot technology, and that achieves extended release. So once the ester, salt, or prodrug forms of the LAI are released into the systemic circulation, they're converted to the active form via various mechanisms, and patients may prefer water-based LAIs because, again, as I mentioned, they may be less painful. But Les, what does that mean then for currently available formulations? Let's put this into practice.
Well, I like to think of long-acting injectables as a guaranteed delivery mechanism for antipsychotics that people need to take every day and rather indefinitely. And the guaranteed delivery aspect of it is really critical here because people have fluctuating periods of insight, and it's frankly difficult to remember to take something every day for anyone with a chronic illness. So let's get to what's available. In the United States, we have first generation LAIs such as fluphenazine decanoate and haloperidol decanoate. And Professor Correll, as you mentioned, these are based in sesame seed oil and rather technically more difficult to administer than a water-based injectable. Both fluphenazine decanoate and haloperidol decanoate are generally injected into the muscle, although fluphenazine decanoate can be injected subcutaneously. That is rarely done. Fluphenazine decanoate is generally administered every 2 weeks and haloperidol decanoate every 4 weeks. But these are first generation antipsychotics and come with some baggage, in particular movement disorders such as drug-induced Parkinsonism and dystonia and so on. And really, we've gravitated towards second generation long-acting injectable antipsychotics, of which we have three essential molecules here. We have the risperidone or paliperidone family of choices. We have the aripiprazole family, and we have currently one candidate for the olanzapine family. Let me go through these in sequence. With risperidone microspheres every 2 weeks, we had the first second generation LAI in our hands, and it was very popular very quickly. But it's every 2 weeks. And paliperidone palmitate emerged as, in my mind, a replacement for this. Remember that paliperidone is the main active metabolite of risperidone. It's also called 9-hydroxyrisperidone. And paliperidone palmitate was initially available as a once-monthly injectable. Another key differentiating factor was that risperidone microspheres required a 3-week period of oral supplementation upon initiation, whereas paliperidone palmitate could be initiated without any oral supplementation at all. However, you do need 2 injections at the start, separated by about a week difference. And then paliperidone palmitate became available every 3 months or every 6 months for those who were successfully treated with the once-monthly formulation. Now, newly available is a subcutaneous formulation of risperidone, a polymer that's injected subcutaneously. And right from the start, it can be injected every month or every 2 months without a loading dose and without oral supplementation. So that's the risperidone and paliperidone family of injectables. And we have now the aripiprazole family of 2 choices. Aripiprazole monohydrate, which was the first to come on the scene with a monthly injection, together with a 2-week oral supplementation period at initiation, and aripiprazole Aroxil that first emerged every month or every 6 months as a potential interval for injection, and that required a 3-week oral supplementation period. But over time, the aripiprazole Aroxil option also emerged as an every 2-month option, as well as an option to initiate it in 1 day with a second injection and a single oral dose. Aripiprazole monohydrate emerged rather recently as an every 2-month option, and outside of the United States, there is a way to initiate it in 1 day with 2 injections and a single oral dose. In terms of olanzapine, right now, what we have is olanzapine pamoate that can be given every 2 or 4 weeks. It's given IM without an oral supplementation, although a higher dose is given, and then ultimately a maintenance dose is given it's somewhat reduced. But a major disadvantage there with olanzapine pamoate is the requirement by a REMS for observation for 3 hours after each injection because of the risk of post-injection delirium sedation syndrome, which happens in 0.07% of injections. Not very often, but often enough to require this 3-hour observation period where patients need to be in the clinic or office and they need to be accompanied home. In the works is a polymer version of olanzapine long-acting injectable to be injected subcutaneously. Now, I wish there were other molecules available to administer in a long-acting formulation. Maybe there will be in the future, but right now this is what we have.
Well, that was really a very nice summary. Thank you so much, Professor Citrome. Well, let's hear from Dr. Roma. How do we actually start LAIs, and when should we be doing this in the treatment plan? Is it something as a last option, as we've heard for decades?
So thank you for that. Actually, historically, long-acting injectable antipsychotics were used in patients who already had chronic non-adherence, already had failed multiple oral formulations. But I think that given the fact that there have been multiple studies now comparing outcomes of long-acting injectables versus oral, and long-acting injectables delaying time to relapse, keeping patients out of the hospital, as well as helping with morbidity and mortality of schizophrenia, the American Psychiatric Association now is recommending earlier use of long-acting injectables. In fact, this group here, and the reason why we're doing this presentation is because we all believe in the benefit of long-acting injectables early on in the course of schizophrenia. So let's dive a little deeper into what the American Psychiatric Association practice guidelines of 2020 actually say. First of all, they say that you should be using long-acting injectables in patients who prefer long-acting injectables. Well, if you're not offering a long-acting injectable formulation to your patients, how do you know whether or not your patient prefers a long-acting injectable? Secondly, they're saying that long-acting injectables should be used not only in patients who have chronic non-adherence, but in any patient who has a risk of non-adherence. And those risk factors are enumerated as: one, if a patient is changing treatment settings. So going from inpatient to outpatient, going from incarceration to the community, any of these transitions are possible stumbling blocks to create medication gaps for our patients. So transitioning settings, comorbid substance abuse, because our patients who have comorbid substance abuse have higher risk of forgetting doses, as well as poor insight into the need for medication. So all of these risk factors have now been enumerated, and it has stated that it may be appropriate to start long-acting injectables earlier in the course of disease. So how do we have these conversations? When should we have these conversations? It's suggested that even as early as first episode psychosis or early stage schizophrenia, that is when patients may benefit the most. We should be bringing up the option of long-acting injectables with every conversation until the patient is ready and able to accept that treatment. We should use things such as motivational interviewing to help explore some of the resistance that we might get back from patients and family members. You know, if we think about it, first episode and early stage schizophrenia, that's before there has been a lot of brain damage, treatment resistance that has developed. So if we offer long-acting injectables and we're able to delay time to relapse or reduce relapses, perhaps we can reduce some of this co-occurring damage to the brain. We can reduce some of this treatment resistance. We can reduce some of the polypharmacy that we see happening throughout the US. So early use of long-acting antipsychotics might help to increase treatment response. It can prevent relapse, and as I've suggested, reduce some of the structural neurologic changes that we see early on in disease. We see these changes as early as the first and second relapse. So given that, and given that our message, the American Psychiatric Association's message, the National Council of Behavioral Health's message is to start long-acting antipsychotics earlier, let's look at some of the advantages and the disadvantages of long-acting injectable antipsychotics. Well, first of all, as Professor Citrome had said, it's easier to measure and confirm adherence because your patient either shows up for their injection or they don't show up for their injection. And so they're either getting 0% or 100% of the dose. It eliminates the need for daily oral medication. It reduces the risk of overdose. And I think other than adherence, what we often see with our patients is partial adherence. And that's when the question comes up, what dose of your medication is your patient actually on? You know that with certainty if a patient is on a long-acting injection. So we're reducing the risk of rebound symptoms and abrupt relapse. We are, again, decreasing these peaks and these troughs that can occur with oral medication in serum concentrations of the medication. And we will still have regular contact with our patients to monitor them and see how they're doing and to observe whether or not they're having breakthrough symptoms. So what are some of the disadvantages? Well, we talked about first generation antipsychotics and second generation antipsychotics. And oftentimes I hear people complain about the cost of second generation antipsychotics. Well, think about the cost of just a single day of hospitalization or the cost of work lost in our patients who are having relapses. Limited flexibility for dose adjustments, delayed time to reach steady state in some formulations. If a patient should have an adverse effect or a side effect, sometimes we're worried because we can't undo the fact that we gave them a long-acting injection, so they have prolonged exposure to the culprit. Pain and burden of injections. Sometimes people don't have facilities where they think it's convenient to give an injection. And then we have travel and other logistics for injection appointments.
Well, that was a very nice summary, grounding us in the pros and cons, but also what to bring up during a discussion in order to introduce patients and caregivers who may actually help us discuss with the patient that this might be an option to use an LAI in order to find out that maybe the illness and the brain can function in a different way and there's more degree of freedom when having LAIs, because sometimes there's this lure like, oh my God, I'm giving up control, I'm being controlled by medication. Well, we want to give patients back degrees of freedom and functionality. But when trying to do that, we have to transition from an oral to an LAI formulation. And so we need to bear in mind 3 things during that transition. First is how to start the LAI. Second, how to discontinue the oral treatment. And third, how to maintain the LAI. So first of all, before you give something that lasts 2 weeks, 4 weeks, 8 weeks, 3 months, or even 6 months, you want to know that this medication in an oral formulation at least doesn't cause an allergic reaction. And some of us may even feel that you need to give it for a certain time, that tolerability is established. And some of us might even want some efficacy signal. You can either glean that from the past or have a lead-in phase with an oral medication. Then the oral to dosing, LAI dosing conversion is provided in the labeling of the medications. And basically, it has to do with some of the pharmacokinetic characteristics of the drugs that Professor Citrome was talking about. So there are treatments that have to be given with an overlap of oral treatments. So for example, 3 weeks with biweekly risperidone microspheres, 3 weeks with our aripiprazole Oroxol, 2 weeks with aripiprazole monohydrate. But then we have now 2 injection starts with, approved in the United States, microspheres of aripiprazole Oroxol plus the regular injection, or hopefully coming to the US soon and being approved in Europe, having a 2 injection start of 400 milligrams of aripiprazole once monthly. We can have drugs that need a loading dose. You start at a higher dose and in the deltoid compartment, like for example, paliperidone, and then you need a booster injection 1 week later. There are other treatments that don't need that, like already mentioned, the subcutaneous form of risperidone and the one that's in development for olanzapine, where within a day you get therapeutic blood levels without having a booster injection, without having a loading strategy, or also the need for oral co-treatment. So this can be considered when starting the medication. Generally, when you come same to same, you can then down titrate after steady state is reached, or during the reaching of the steady state, the oral medication goes down. But when you come from, for example, a more sedating drug or a more antidopaminergic drug, going from a pene to a done or a PIP, so olanzapine, for example, quetiapine, to risperidone or paliperidone or aripiprazole, you may want to overlap a little longer so that there is no rebound from the sedation. Same when you come from a full dopamine blocker like risperidone or haloperidol and you go to a partial agonist, again, take a little bit longer for the weaning of the prior oral medication that has more blockade on receptors that the new drug wouldn't have. And then we have to maintain the medication and choose the right injection interval. There are often choices now, which is wonderful. You have risperidone options that can be given every 2 weeks, once a month, or even 2 monthly. There are aripiprazole options that can be given once a month, every 6 weeks, or 2 months. And then you know the paliperidone option, you go either once a month, every 3 months, or 6 months. But to get to 3 or 6 months, you have to have at least 5 injections and 4 months of the 1 monthly injection, or basically also 2 doses that are the same and maintained before you go to the 3 monthly. And then the injection goes either into the deltoid, which is a smaller compartment. It's necessary for the first injection for paliperidone, but otherwise you get higher peak values when you go into the deltoid, and you get longer half-lives when you go to the dorsogluteal side. And that all has to be discussed with the patient, what they prefer, and also looking at the duration and durability of the medication effect. There is PDSS with the current intramuscular olanzapine, as already mentioned. That's the post-injection delirium sedation syndrome, and we hope that the subcutaneous form will not have that. And then injection volume, length of the needle, and need for reconstitution or refrigeration are also all considerations when to consider going from an oral to an LAI formulation. But let's enter now the last chapter before we close our first session of the sequence of 4 programs. Professor Citrome, what are potential adverse reactions and effects of LAI treatments, and what's the monitoring need?
Well, the good news is that the systemic adverse event profile for any of the LAIs reflect what the patient would have experienced with the oral formulation. So when we go from oral to LAI of the same molecule, I wouldn't expect anything different. If anything, you'll be likely to use a lower overall dose because you're going to have guaranteed delivery of the injectable dose rather than the varying degree of oral adherence. That's a big question mark before the injection strategy was adopted by that patient. So I think there's no surprises here. However, injection site pain is a concern about that patients have, and they heard about needles. They don't like needles, and there are a few things that I'd like to say about that. One is to the patient, this is not like the needle you got in the emergency department when you were held down by 4 people because you were agitated. This is a voluntary administration of an injection into the muscle, sort of like that flu shot that you got a month or 2 ago or something like that. And then I would tell them, research has been done with regard to injection site pain, and they ask patients regarding how painful is something on a scale of 0 to 100, with 0 being no pain and 100 being excruciating pain. And the research tells us that patients rated this in the single digits, certainly less than 10, and in many instances, less than 5 out of 100. So this puts it into perspective. If they actually have a tattoo, I point out that tattoo hurt a lot more than what we're talking about. I also mentioned this is not, if someone has a history of intravenous drug abuse, this is not injected into a vein. It's injected into a muscle, which is technically much easier than what you did on your very own when you were abusing heroin or whatever. So I do take into account a patient's experiences with needles, try to incorporate that into the conversation when talking about injection site pain. Sometimes there's some hesitancy from the prescriber that they're not worried about the side effects. They're worried about, is it going to work? And I ask them, well, how long are you going to wait until you decide whether something is working or not? And I'm usually told about a month. And I said, well, if you give a once monthly injectable, you'll know your answer and you don't have to worry if they took the medicine or not. So there are many advantages to LAIs. I really like the guaranteed delivery aspect of it. And if you know the molecule, you will know about the LAI.
Well, thank you very much. That was really a very well-rounded group discussion and presentation. Maybe, Dr. Roma, do you want to give a little clinical pearl, last 30 seconds, each of you, before I thank the audience for their participation?
I just want to say that oftentimes it's not the patients who are refusing the long-acting injectables. When I think about what's holding us back, I tell people to hold up a mirror, because if we're excited about it, then our patients will be excited about it.
That's a wonderful closing quote from you. And Professor Citrome.
Well, I spent most of my career in the state hospital system in New York. I wish I can go back in time and treat those patients earlier on and encourage them to take an LAI. They would not have ended up in the state hospital.
Again, introducing this medication option earlier to change the trajectory of the illness. Well, I want to thank the audience and obviously thank you too for joining me. This was part 1 of a 4-part program, Navigating Schizophrenia. And please join tomorrow, same time, A Path to Stability, using long-acting injectables in order to select the right treatment. And this will be given again with Professor Citrome, but also Professor Deanna Perkins. We want to thank you for participating. Please scan the QR code to claim your CME credit, and we hope to see you tomorrow again.